Thank you very much for the introduction, and also it's a pleasure to be here today. I'm going to follow what Gary and Bernard started on what do we need in the clinical trials with a focus on progressive MS and advanced MS. But obviously, I'm going to focus on the imaging measures, and I'm going to discuss from a neuroimaging point of view. So these are my disclosures. As you see, my research is funded by the International Progressive MS Alliance. So this is the outline of my talk. I'm mostly going to focus on atrophy-based measures, mostly on brain, but also on the spinal cord. And I'll show you results from previous trials, but also how we can use them to refine future trials. A little bit on advanced MRI, the MRI that is not used in the clinical practice. And also, finally, we just touch on the new outcome measures that can be used in combination as composite or combined measures with imaging, in addition or with imaging. And also, this is at the limits meeting, so lots of limitations for each measure. I'll also mention the limitations when it's necessary. So any outcome, imaging outcome for progressive MS, or in general for MS, first it must be reproducible. So when you think of the clinical measures compared to imaging measures, what we can gain and the advantage that imaging measures can give us is being more reproducible, because you don't end up with having multiple raters, and many of these measures that I'll show you, they can be measures in the central reading center, for example, for a trial. And the other thing is what Gary mentioned, what you would expect in 2 or 3 years of a trial, you want something to change. So for example, if we recruit for advanced MS and patients have an EDS of 6 or 7 over 2 years, you wouldn't expect to see that much change. So I think this is another advantage we can get from imaging to make sure actually there is a decline, there is a change, so we can capture that using imaging. And finally, imaging is very attractive, but is it meaningful? So we need to focus, and I'll mention which of these many different imaging measures can be meaningful for patients, and they can actually have some impact on the outcome that is important for patients. So what has been used for a very long time in RRMS, in relapsing remitting MS, as the outcome measure is the lesion and the lesion loads. What we see here, there are 2 different meta-analyses from Maria Pia Sormani. What you see on the horizontal axis is a treatment effect on T2 lesions. And what you see on the y-axis is the treatment effect on relapse rate. And what we see there is a very robust relationship between what we see on the lesions and what you would expect on the relapses. But we know that this is not sufficient for progressive MS, mainly because lesions, they don't capture the neurodegenerative process, but also because we don't see it. There was the second feature of an ideal outcome was to see a change. We may not see any change with lesions if we use as a measure in advanced disease. So for this reason, we see the appearance of brain atrophy over the past 2 decades as the primary outcome in phase 2 trials, and also as a secondary outcome in phase 3 trials. So there are lots of different techniques to measure atrophy. I have classified them into 2 different groups. In red, these are the longitudinal measures that we require 2 different scans to measure the change. And the ones you see in blue, they can be used cross-sectionally, and therefore they don't require necessarily 2 different scans in a trial. So Sienna, this has been used most widely, certainly for more than a decade, and what it gives us is basically a map based on 2 different MRIs. It gives us a map on the boundary of the brain, looks at the boundary and the change in the boundary of the brain, and also the ventricles. And you get a map of change where you see a growth or you see an atrophy. And what you get at the end, and I think that's the important point, is just to take from the slide, is something called PBC, or percentage brain volume change. It usually changes from 0 to 1.5. So we look at one trial. This is the Oratorio trial, and this is the outcome measure. You see the start is at 24 weeks to adjust for pseudoatrophy. And what we see, patients who were on ocrelizumab, these are patients with primary progressive MS, and Bernard showed us the effect on EDSS. I'm showing the same trial. This time, the effect has been assessed by Sienna on brain atrophy. And you see after 120 weeks, there is a change, about 18% change. So again, the first limitation of brain atrophy is quite delayed. It takes almost 2 years to see any change in this trial on hundreds of patients. And the other trial that was recently used, Sienna, was the EXPAND trial, the trial on patients with secondary progressive MS that were on siponimod. You see patients on siponimod and patients on the other treatment, the placebo arm of the trial. And what we see, there's a significant change after 12 months. Again, this is another application in progressive MS using Sienna. So the other method that, again, uses 2 different scans to look at the change over time is called boundary shift integral, or BSI. It's very similar to Sienna. Again, looks at the boundary. It requires 1 step of segmentation, but the results are almost the same as Sienna. But the only reason I have a different point for this one is because this has been used mostly in Alzheimer's disease trials. And basically, in the MS field, we are somehow borrowing this outcome measure from Alzheimer's disease. Where has it been used? It was used in 2014 in the phase 2 trial of the simvastatin by Jeremy Chataway. What you see after 25 months, there's a significant change. So this is one application of BSI. But compared to Sienna, this has been used much less. So the other measure is called brain parenchymal fraction. This is not a longitudinal measure. It works on cross-sectional measures and looks at the ratio of the intracranial vault that is occupied by the brain, as you see here. And this was recently in a phase 2 trial of ibudilast was in patients with secondary progressive MS and primary progressive MS was applied. And you see after 96 weeks, we see a change using brain parenchymal fraction. So again, this is another emerging measure that can be used to assess brain atrophy. But more recently, since probably 2009, 2010, there is a surge in interest in using more detailed outcomes, looking at different components of the brain, for example, looking at different regions, looking at gray matter or smaller brain areas. And that is what is called regional atrophy. So you try to dissect out what you see on the whole brain level to different regions. So why is it important and why do we even need to do this? Because this is a study from the Cleveland Clinic from Brett Fisher a decade ago when they looked at the rate of brain parenchymal fraction. It was mostly driven by the change in the gray matter change. So what we can hypothesize is, at least in MS, most of the change can be seen, at least ongoing change can be seen in the gray matter. There is certainly significant atrophy in the white matter. What we are actually interested in is not atrophy itself, but whether or not it changes over time. So this is what it's showing us over time. There's more change in gray matter than, for example, white matter. So it might be worth even trying to dissect out gray matter into different regions. So what we see here, these are the results from a Magnums study on more than 1,200 patients from different parts of Europe. What you see on the y-axis, on the vertical axis, is the percentage brain volume change. And what you see here, there are 5 different groups: healthy controls, patients with CIS, RRMS, and progressive MS. And these different colors are different brain regions, mostly in gray matter, but also what we see here is the whole brain atrophy. So but just looking at the figure, you see that there is one area, this bar plot, this gray bar plot, that shows accelerated atrophy, even in healthy controls, is quite high. This is deep gray matter. So, but the other area that is very specific to progressive MS is not deep gray matter, but it's the cortex. So these bar plots you see here, if you perform statistical significant tests, you'll see that the cortical areas are actually more specific to MS compared to more specific to progressive MS compared to the relapsing-remitting MS. And again, comparing this with the whole brain atrophy rate, you see the regional atrophy rate could be 2-3 times higher in these smaller structures. So what happens if you apply this in a clinical trial? So a recent post-hoc analysis of the Freedoms trial by Laura Gaetano, she's from University Hospital Basel. They looked at, they reanalyzed the Freedoms, which was a fingolimod versus placebo in patients with RRMS. This is not progressive MS, but in RRMS. And they reproduced the results on the whole brain volume. You see there's a change. But what happens when you look at the deep gray matter? Deep gray matter includes thalamus and a few other nuclei in the brain. And first of all, you see, you're just looking at the y-axis, the rate of change. You see, compared to whole brain change, the change on the deep gray matter, this regional change, is at least 2-3 times higher. The second point is if you try and look at the dose-dependent change in patients on different dosage of fingolimod, we see a dose-dependent change if we look at the regional atrophy, whereas we may miss it if we just look at the whole brain level. It also shows that if obviously you get higher statistical power if you use this regional atrophy. Again, this is in RRMS. It's less clear what can happen in progressive MS. So there are lots of studies that have looked at the regional atrophy in progressive MS, SPMS, and also PPMS. This is my study. I'm presenting this again. This is from the Magnums network. And what we try to do, we try to there are more than 60 brain regions that we parcellated the brain into different regions. We use the Kaplan-Meier survival curves at each region, try to predict over 2-3 years the change in EDSS. And what you see again, what comes out is the deep gray matter, in particular here in thalamus, in patients with relapse onset MS, also in patients with PPMS. It was the most important region to predict future change. So what I'm trying to say is that this imaging outcome measure, the deep gray matter, seems to be also clinically meaningful, at least according to EDSS. There are also lots of studies from Milan group. They have found, even before us, that this is also true in independent cohorts. So the point about any outcome measure, it must be reliable in different stages of disease. So the question I'm asking here, is it actually, the thalamic volume, is it reliable at different stages in patients with different disease duration? Well, the answer is yes, if you look at the patients with less than 15 years of disease duration. This is a study from Keck Medicine in California by Cristina Azevedo and the group led by Daniel Pelletier. And what we see that there is a constant, the slope doesn't change, is quite stable. So it looks to be a good outcome measure, at least in patients with less than 15 years of disease duration. But what happens in advanced disease? So by advanced disease, I mean the patients, for example, in this trial, this is a post-hoc reanalysis of simvastatin trial that I showed you the results before. You probably know the trial by Jeremy Chataway. I did a reanalysis of the trial. This time I tried to look at different regions of the brain and to see whether we can capture, with the highest statistical power, the treatment effect. So you see the statin and placebo. There was a whole brain, about a 43% change at the whole brain level. And what we found is actually looking at the thalamic volume. These are patients with very long disease duration, 23, 24 years disease duration with SPMS. And to our surprise, this is the rate in thalamus, and this is the rate is about 0.5, which means that compared to patients with earlier disease, it seems that the thalamic volume at some point, it hits a floor effect. So it declines, but in patients with very advanced disease, 20 to 23 years of disease duration, it may not necessarily be a good outcome measure. So you see that here, for example, the ventricular volume, which is a very non-specific measure, simply reflects the change at the whole brain level, seems to have a higher change over time. So this is basically the results. These are the patients. This is the thalamic volume in the simvastatin trial, the phase 2 trial. And what you see on the right, we used an independent cohort of more than 1,300 patients from Magnums, try to see how, in patients with secondary progressive MS, how thalamus changes over time. And you see after about 20, 25 years of disease duration, again, I just said these are SPMS patients, the thalamic volume goes even less than 67 milliliters. So basically, at some point, the patients, they don't have any thalamus left. So it's important to bear in mind, if you want to run a future trial, it may not be a good idea just to use one region that we think is very much susceptible to MS. So what else can we use? Spinal cord. Spinal cord is, we know very well that is affected in MS. Lesions in the spinal cord, as we can see in this slide. Also, we can look at the spinal cord atrophy, as this is a study from University Hospital Basel. You see, just in patients with progressive MS, there's no statistically significant change, but just look at the numbers, we see there's a trend of loss. So patients with more advanced disease, they have smaller cross-sectional area of the spinal cord. But this is probably not very attractive for trials. I just go back to the ideal outcome. We want to see decline over time. And here you see the decline over time. Again, if you compare patients with progressive MS with patients with RRMS, there is an acceleration in the change in spinal cord atrophy. And if you look at the y-axis, so these are the percentage volume change. And I want you, in your mind, to compare the numbers for spinal cord with the numbers from the brain. What we see that the spinal cord atrophy seems to be 3 to 4 times higher in terms of the rate of decline, at least according to this study. So it could be just thinking of different outcomes, it could be a good outcome measure. Again, this is confirmed by this is a study from Mara Rocca from Milan, and she used 1 year change in the brain and also 1 year change in the spinal cord, and she tried to correlate the change to the EDSS after 15 years. And what she found was using the spinal cord change, you can have a better predictive value to predict future EDSS, not predict, sorry, which correlates better with future EDSS change. So is it useful for clinical trials? Well, unfortunately not, because just looking back from lots of different trials from 2002, we see that the trials that actually use the spinal cord as the outcome measure, they didn't find that much. Most of them, they are non-significant results, which we can actually blame interference. That I saw many people blame interference in this meeting, but also that the spinal cord, it depends very much on the population of patients. So what I mean by the population of patients, this is a study from the Queen Square. What Nim Kohli, she tried to look at 2 different population of patients, so this is a retrospective study. She looked at the change in patients with PPMS. These are patients with 6 to 7 years of disease duration, and another population with 26 to 27 years of disease duration, patients with secondary progressive MS. And she tried to use the spinal cord and also brain, PBVC is the percentage brain volume change, to calculate, based on the 30% treatment effect, the sample size for a hypothetical trial. So you see that in patients with early disease, 6, 7 years of disease duration with PPMS, you get comparable results using spinal cord and percentage brain volume. But if you look at the patients with very advanced disease, the numbers you get from a spinal cord are very much non-feasible, that if you want to run a trial with more than 1,000, compared to what you get from the percentage brain volume change. Again, so what I want to say is, seems to be spinal cord is very much affected. Again, could be the similar story to the thalamus, that it hits a floor effect. But the other issue with spinal cord is the lower resolution we get. Spinal cord measures, I don't think they're ready to be applied for clinical trials. And we still require lots of more development in terms of techniques compared to, for example, brain atrophy that is, in my opinion, is ready at least for phase 2 trials. So we also have other MRI measures. We call them advanced because we probably understand them less, but also because they are not applied widely in the clinical practice. They are less accessible, and for this reason, I say secondary in phase 2, and certainly not in phase 3 big multi-center trials. So one of them, again, I'm going back to the study from Bob Fox, the clinical trial on ibudilas in patients with progressive MS. He used, this is obviously not, it's a secondary outcome. I showed you the primary outcome, which was the brain parenchymal fraction. What you see based on magnetization transfer ratio, which is a MRI measure that we think relates to myelin, but also to lots of other measures. It's very sensitive, but less specific exactly what it shows. But we think it could be related to myelin to some extent. So what you see, patients who were on the treatment arm, ibudilast, they didn't show any deterioration in the MTR over time. But whereas patients who were on placebo, they showed a deterioration, which was significant according to this 95% confidence interval. But advanced measures can also be useful when, this is diffusion tensor imaging, another advanced measure. They can be useful when you want to test a drug that is not necessarily not inflammatory. So if you have a hypothesis regarding some, for example, you're looking at a remyelinative therapy, a putative remyelinative therapy, we can use these advanced measures. So again, these are the results from the ibudilast trial. This is the DTI, the diffusion tensor imaging. There is no change. Again, this is negative. But also the other one, on the right, you see there's a clemastine trial, which was run by Professor Green. And it was negative based on DTI, as you see here, but it was positive. It's a very small phase 2 trial. It was positive based on visual effect potential, which I'm not sure how it can relate to remyelination. But anyway, the fractional anisotropy was used in this trial. Again, this is negative, but it just shows that these kinds of advanced measures, they can be used if you think of a non-inflammatory mechanism for your drug. So I'm just getting to more recent or more cutting-edge applications of the MRI measures, whether they can be used. What I showed you so far was on the trials. And the problem with trials, unfortunately, we look at the groups of patients. So we just basically looking at p-values that may not at all be useful in a practice and may even sometimes be misleading. So what we are actually interested is to look at the individual patients. So unfortunately, this is not possible yet using any imaging measure, but they can be useful in identifying subgroups of patients. And what we see as the combined measures of using imaging and also the clinical measures that they put together, for example, one of them has been used at least for 10 years or so, is the no evidence of disease activity that tries to define a measure for treatment response. So we see this has been used certainly not in progressive MS, but in relapsing remitting MS since 2009 or even more. But the criteria is very simple. So what you would define as a treatment response is no relapse, no change in EDSS, and also no change in T2 lesion. So this is, you see, there's a footprint of MRI. And what I want to say is there also with the newer, so the no evidence of this activity is called NIDA, and NIDA-4 is basically the addition of brain volume change or brain atrophy to NIDA. And the issue becomes, so I think the advantage of this is basically you try to find the subgroups of patients, but adding any MRI measure to the treatment response, you have the issue of choosing a threshold. And unfortunately, these thresholds may not represent other groups of patients, and usually they are based on, for example, a select group of patients, usually from the Western countries. And what was chosen here was a threshold of 0.4. So I think the future is very bright for these sorts of combined measures, but still we see they have been applied. I'm not sure how much they can be useful at the individual level. But this is not very useful for progressive MS. We see the appearance of combined measures that putting together the clinical measures, also what you see, EDSS, the ambulation speed, and also 9-hole peg test here, they come together. This is called no evidence of progression. So these three together, no evidence of progression. We have also no protocol-defined relapses and also no change according to T2 lesions. So this is where MRIs somehow fused with other measures trying to define a kind of treatment response. And we also see the change in GAD-enhancing lesions. So we have here no evidence of progression, and disease activity. So this has been applied to the ocrelizumab trial, to the Oratorio trial. What we see, patients who sustain or maintain NEPAT or no evidence of progression and disease activity, they're 3 times more likely to be on the ocrelizumab arm than the ones are on the placebo arm of the trial. But ocrelizumab trial was a very peculiar trial in which patients with active lesions, patients with progressive MS with active lesions were recruited. So I'm not sure, including T2 lesions, how much it can be useful for future trials. Also, this was applied retrospectively. But again, there's so much promise for putting together different measures, and I hope in future, for example, we can also have a new measure of treatment response in progressive MS, including, for example, more neurodegenerative aspects of the disease, including, for example, brain volume change. Just to summarize what I showed you, first, we saw brain atrophy has been, in my opinion, the most important imaging outcome measure. We saw that there's a focal or regional atrophy early on. During the progression, it becomes generalized, and it affects all the brain over time, especially in patients with advanced disease. Spinal cord, there's certainly more extensive damage compared to the brain, but the spinal cord measures are not yet ready from a technical point of view to be applied in the clinical trials. We see the appearance of trying to subgroups of patients using MRI measures, and this certainly allows identifying subgroups of patients, but we have still, I think, a few decades of research in order to get to individual patients. At the end, I want to thank all the colleagues at the Queen's Square, and also thank you for your attention.